Hello, everyone. I am Dr. Rennie Butler at Yale University School of Medicine. I'm here to talk to you today about digital breast tomosynthesis. Thank you for inviting me. I would like to start by sharing with you the current guidelines of the American Cancer Society, and then we'll continue on to some evolving, potentially additional guidelines. In 2007, the American Cancer Society issued recommendations for breast cancer screening in women at high risk. This high risk category is defined as a lifetime risk of 20 to 25% or greater, and it includes the following patients: women who have a known BRCA mutation or other genetic variation that predisposes them to a high lifetime risk, women who have no identified genetic mutation, but in whom some of the risk assessment models, such as BRCA-Pro or Tyrer-Cuzick, have calculated that they have a high lifetime risk of 20 to 25% or more. Women who have had a diagnosis of Hodgkin's lymphoma and been treated with radiation to the chest between age 10 and 30 years of age, and a number of relatively uncommon hereditary syndromes, including Li-Fraumeni, Cowden, and Benny-and-Riley-Ruvalcaba syndromes and their first-degree relatives. The evidence is strong that breast MRI is effective in detecting many additional cancers in these high-risk patients. And when we compare across modalities, we can see that the incremental cancer detection rate, here abbreviated as ICDR, really jumps when we move from the anatomic modalities of mammography, including digital breast tomosynthesis and ultrasound, to modality like MRI that not only has anatomic information about the morphology of breast cancers, but also incorporates functional information about their vascularity. To keep a perspective on these incremental cancer detection rates, we want to remember that the typical cancer detection rate generally in the nation is approximately 5 to 6 per 1,000 women screened. So with that in mind, the additional cancer detection that's offered by digital breast tomosynthesis is on the order of an additional 0.2 to 2.8 per 1,000 women screened. Ultrasound does a little better than that, with an additional 2.3 to 4.2 cancers per 1,000 women screened. But MRI really jumps forward and increases the cancer detection rate manyfold to 10.6 to 30 additional cancers per 1,000 women screened in intermediate and high-risk women. And here's what that looks like in a clinical case scenario. This was a 69-year-old BRCA1 positive woman who just had a normal screening mammogram. This MRI shows us axial imaging from the early phase and the delayed phase. And in dynamic contrast enhanced MRI, we always want to do multiple phases of contrast shortly after injection and sometime later after injection. This helps for us to know exactly how the kinetic behavior of the area performs and in whether or not it's likely to be malignant. In this patient, the early image after contrast injection shows a brightly enhancing, slightly irregular mass. On the delayed image, we see that it's not as bright. We call this kinetic behavior washout, and it is strongly associated with cancer. We did an ultrasound following the MRI, what we call a MRI-directed or second look ultrasound, and this did not show the finding. The mammogram, again, was also normal, and therefore this was biopsied with MRI. This is an image from the MRI biopsy that shows this black signal void from the biopsy needle with a little bit of a bright hematoma around it. And this turned out to be an invasive ductal carcinoma. It was a triple negative cancer, which fortunately had no axillary lymphadenopathy at the time of diagnosis. Another example, in a 59-year-old high-risk patient, this woman had had genetic testing. No genetic variations were identified, but she had a strong family history of breast cancer in multiple first and second degree relatives that led to her being classified as having a high lifetime risk greater than 20%. This woman also had had a recent normal screening mammogram. And again, what we see here is that in the early post-contrast image, we have a little enhancing mass, which on delayed imaging is less bright, again suggesting this washout kinetic behavior that we associate with breast cancers. Similar to the first example, this patient had a normal mammogram and a normal ultrasound, even going back to look for the area of abnormality on the MRI. Nothing was seen on the ultrasound. This was also biopsied with MRI. Here again is the biopsy needle, signal void, and a little bit of hematoma. And this was shown to be grade 2 DCIS. So an early diagnosis of a highly treatable cancer. Where there is some more debate is with regard to the intermediate risk category of women at a lifetime risk of 15 to 20%. For this category, the 2007 American Cancer Society recommendations stated that there was insufficient evidence to recommend for or against MRI screening. These women include patients who've had a prior biopsy showing a high-risk lesion, such as a lobular carcinoma in situ or atypical lobular hyperplasia. Atypical ductal hyperplasia is another high-risk lesion. It also includes women with a personal history of breast cancer, a really important category that we'll look at more closely with some additional data. And it includes women with heterogeneously or extremely dense breasts on mammography, which we know means that their sensitivity of the mammogram is much lower, but it also means that this is an independent risk factor for increased breast cancer risk. Multiple studies have shown that women with a personal history of breast cancer have a similar rate of cancer detection on MRI as women with a genetic or family history of breast cancer for whom MRI is recommended. Here, PH signifies personal history and GFH signifies genetic or family history. These are women already in the high-risk category for whom MRI is performed as a supplemental screening test. And these are women in that intermediate risk category for whom the American Cancer Society has so far said that MRI is neither recommended for or against. But when we look at the cancer detection rates, they're quite similar. The specificity is also very similar. And these are multiple studies, and others are also emerging that support this data. Another source of recommendation for MRI to be considered for women with a personal breast cancer diagnosis is this modeling that was performed at Dana-Farber and reported a few years ago. And what this shows is that women who are treated with lumpectomy, with tamoxifen or without tamoxifen, fall into this high risk of a greater than 20% likelihood of a second cancer, at least until about age 67 or 68. So it may be that they don't always need a supplemental screening MRI, but it may be that they would benefit from a supplemental screening MRI from the time of diagnosis, if they're diagnosed relatively young, until approximately 70 years of age or a few years earlier than that. These are women who are treated with mastectomy, with tamoxifen or without tamoxifen, and these women did not fall into that high-risk category with a threshold of 20%. So the takeaway points from these data that we're learning about is that, as we've known, cancer detection is significantly increased by manyfold in high-risk women with supplemental screening MRI. The recommendation for screening women who are known to be at a greater than 20% lifetime risk is widely accepted. The recommendation for screening women at 15 to 20% lifetime risk is evolving. However, the data supports that screening MRI in women with a personal history of breast cancer who have been diagnosed prior to age 50 and women diagnosed at any age who also have dense breasts may be helpful.